Good morning. Today we're going to talk about antibacterial agents. In order to talk about bacteria, we must understand the classifications. Bacterial comes in rod shape, which are called bacillus, or spherical shape, which are called cocci. Staphylococci is a cluster, streptococci are chains, and then they also come in spiral shape. Spiral shaped is mainly our syphilis type bacteria. Okay, bacteria is classified by gram positives or gram negatives. In 1882, Christian Graham actually devised the gram staining, which determined the ability of the bacteria's cell wall to actually retain a purple dye. This purple dye, if it stains or if it retains that purple stain, is a positive classification, which is usually associated with staph or strep. And if it was a negative, where it did not retain the purple dye, that usually indicated E. coli or H. influenza. So, that's how we determine some of our classifications of bacteria as far as gram positives or gram negatives. Okay, antibacterials actually originated naturally through the penicillium mold, which was discovered in 1928. And that was where we had the molded bread, and that created the penicillin that helped treat infection for many years. Then we went into the manufactured antibacterials, which was sulfonamides in 1935. The actions of antibacterials are either bacteriostatic or bactericidal. Bacteriostatic means it inhibits the growth of the bacteria, and this is usually found in our tetracyclines and our sulfonamides. Then we have the bactericidal, which means kills bacteria, and this is found in most of our penicillins and cephalosporins. So bactericidal, think of suicidal, it's going to kill. So static inhibits, cidal kills. The therapeutic ranges of antibacterials are usually obtained with a narrow therapeutic index, and we do that by peak and troughs. And peak is the serum antibiotic level to measure the maximum amount in the patient's system, and we check for toxicity. Do y'all remember when we check the peak? The peak is after the dose is administered. Okay, and if the peak is actually too high, then they are considered serum toxic. The trough is drawn approximately 30 minutes before the next dose is due, and we check for adequate dosage. If the trough is low, then they're not receiving enough to kill that microorganism, so then we would have to adjust the dosage. I won't spend a whole lot of time on this slide, but antibacterials have many mechanisms of action. They can actually inhibit cell wall synthesis. They can change membrane permeability, inhibit protein synthesis, inhibit synthesis of bacterial RNA and DNA, and interfere with cellular metabolism. And these are all different ways in which it actually fights the bacteria. Resistance to antibacterials is obvious. We've heard about it with methicillin-resistant Staph aureus, the MRSA that has been out there, but resistance can actually be inherent or acquired. Inherent means that it just occurs without any previous exposure to the drug. They're just naturally resistant to the drug, as opposed to the acquired resistance, which is what we hear most commonly with the MRSA, is caused by prior exposure to medication, and the bacteria reproduces, mutations occur, and then the bacteria is no longer susceptible. There are many ways that we can actually combat the resistance to antibacterials. The first one on your list is to use a combination of two medications. And what we mean by that is when there's a severe infection that persists and it's been unsuccessful with the treatment of just a single dose antibiotic, let's combine it with two antibiotics to go ahead and knock it out, eradicate it, get it going. Because what we do is we wind up continuously treating them with one antibiotic for a long period of time, and that resistance builds up. The second one on your list says develop drugs that disable the antibiotic resistant ability of the bacteria. And these drugs include things such as vancomycin that was created to help with resistance to MRSA. The third one is develop bacterial vaccines. Very important. Why don't we take care of the process, the diseases that can cause infection, or the things that can cause infection. Let's go ahead and eradicate those things so that we're not having to constantly treat with antibiotics. So one that comes to mind would be the pneumonia vaccine. You know, we treat that with antibiotics. So if we give them the vaccine, that's going to decrease the likelihood of that exposure to that antibiotic. And then stop the antibiotic misuse. Now, this used to really be a big problem. It's less now than it used to be. But the misuse is the overprescription or overprescribing of antibiotics for anything just as minor as a viral infection. We used to go to the doctor and say, oh, I got a stuffy nose. They would put you on or a runny nose. They would put you on antibiotics. So now the doctors are less likely to prescribe those antibiotics unless it is a true infection and if it's showing very indicative signs and symptoms of that. Okay, this was one of your questions on your study guides, and that's the adverse reactions to antibacterials. The adverse reactions that are most common is allergy, superinfection, and organ toxicity. With allergies, we have, it can be mild to severe, mild such as rash, pruritus, and hives, and we treat that with an antihistamine. Or it could be as severe as anaphylactic shock resulting in vascular collapse, laryngeal edema, bronchospasms, and even cardiac arrest. Usually occurs within 20 minutes after administering the antibiotic that they're having anaphylaxis with, and we treat that with epinephrine that's going to aid in the shock of the vascular collapse and cardiac arrest. We're going to give them bronchodilators to help with the bronchospasms and dilate the bronchioles. And we're also going to give them antihistamines, which would be your Benadryl to help treat the allergic reaction and the body's defense to actually release the histamines. Superinfections is a secondary infection that actually occurs when the normal microbial flora of the body is distributed during antibiotic treatment, especially for the treatment regimen greater than 1 week. What we see is they might be given an antibiotic for pneumonia, and since they've been getting that antibiotic for a long period of time, it destroys the normal flora that's already there, and what we result in is more or less a lot of times fungal infections, which we can see thrush in the mouth, which we can give nystatin for. You can get yeast in the perineal area as well. So superinfections do occur, and when they do occur, it's usually in the mouth, the respiratory tract, can occur in the intestines, skin, genitourinary, and most of these we treat with antifungals. The last adverse reaction is organ toxicity. Most all of your antibacterials are toxic to the Your antibacterials can either be classified as narrow or broad spectrum. What do we mean by narrow? That means it's effective against only one type of organism. It's narrow, and that's usually gram-positives only. If it's broad, that means it's effective against both positives and negatives. And we usually use our broad spectrums when there's not been a culture and sensitivity obtained, because it's so broad it can actually help eradicate a lot of potential bacterias. So can you think of a broad spectrum antibiotic right off the top of your head? The one that comes to mind for me is always Rocephin. Rocephin is a good one. It is a cephalosporin, and it is typically prescribed first, and once the culture and sensitivity is resulted, it will be evaluated for appropriateness for that prescription regimen. Okay, let's get started into our classifications of antibiotics. We're going to start with penicillins. We'll go to cephalosporins, then we'll go to our mycin drugs, tetracyclines, aminoglycosides, and we'll progress through to sulfonamides and so on. So how do you learn the drugs without having to learn every individual? So what I want you to do is picture it as this is one huge umbrella. The umbrella is actually the class. The class is penicillins. Well, what falls underneath this umbrella? And what falls underneath this umbrella is all the penicillin drugs that are there. Well, how will I know that they're penicillin drugs? Most penicillins end in cillin, C-I-L-L-I-N-S. Okay, so penicillins typically end in penicillins or end in cillins. So my umbrella is penicillin, which is my class. I know the drugs that are there because most of them, I can't say all 100%, but most of them end in cillins. So the drugs in that category would be penicillin G, penicillin V, amoxicillin, ampicillin, bicampicillin, nafcillin, piperacillin, amoxicillin, ampicillin, ticarcillin. So there's so many, but if you see the commonality here, the umbrella is penicillin. They